I have 2 o'clock. I do see a number of people are still joining, but I think I'll go ahead and get us started. I just want to say good afternoon to everyone. I am Jess Bunting. I'm the Assistant Director of Research to Practice at CPWR, and I am the host for the CPWR NIOSH COVID-19 webinar series. I'm typically the silent host, but you'll be hearing from me today. I'd like to welcome you all to our event on vaccination and ventilation, just sort of starting the conversation about next steps in COVID-19 prevention. So our goal for this webinar is to host a discussion about 2 areas where the information is really still evolving when it comes to COVID-19 exposure prevention, and that's ventilation on construction job sites and the vaccination of workers. So we'll present some updates and basic information about these topics, and then we hope to devote a big chunk of time to Q&A. Dr. Scott Ernest, Associate Director for Construction in the Office of Construction Safety and Health at NIOSH, is here and will start us off with an overview of some of the newest resources and information to come out of NIOSH and the CDC. And then after Scott, we were originally going to hear from CPWR's Executive Director, Chris Keene, about ventilation. Unfortunately, she is unable to make it today, so instead I will be giving a very brief update on CPWR's efforts to address ventilation for COVID in construction. And then I will hand it over to Dr. Jeffrey Levin, who will fill us in on the basics of vaccination, what you need to know about the COVID vaccine. And after his presentation, we'll get into the Q&A. Since Chris is unable to be here, and we were fortunate enough to get Dr. Doug Trout from NIOSH to join us as well today, we are going to really focus on the vaccination questions. We received a bunch of questions through the registration process, so we're going to try to get through those first. We'll also get to live questions as time allows. Dr. Ernest will touch on a few ventilation questions that we received, but we're really going to keep the focus primarily on the vaccine. Any questions that you submitted or that you type in live that we don't get to today, those will be used to inform future webinars as well as other work from CPWR. And with that, Scott, let me give you control. I will go ahead and hand it over to Dr. Ernest.
Okay, thank you, Jess. It's great to be here today and great to spend time with everybody that was able to join with us. I'm going to just give a few updates on some of the things that have been going on within CDC. I wanted to briefly touch on the new construction COVID checklists that were developed. Those were initially developed out of our Sector Council work group for COVID. It's chaired by Travis Parsons with the laborers and Mike Mills with Liberty Mutual. Professor Sang Choi from the University of Wisconsin was involved in helping to develop that, and it went through the CDC clearance process and is now available on our website as PDF forms. And I wanted to mention that they're not only available in English, but they've been translated into Spanish. And so with that, let me go to the first checklist. And the first checklist is for employers. And that checklist addresses issues such as how to conduct a hazard assessment, and also gets into issues of controlling and preventing the spread of COVID-19. One of the nice things about this is there's a lot of hyperlinks throughout these documents. So if you click on the hyperlink, if you're online or on your phone, you'll get to other resources that are helpful. It's just a embedded document. And then also another important thing is that on this particular checklist, it points to the exposure control planning tool that was developed by the National Construction Center, CPWR. And so there's information there. It's a very useful interactive tool you can get to through the hyperlink. So that's the first page for the employer. And then the second page for the employer checklist gets into issues such as managing of sick workers, safe transport of workers that are sick, quarantining. It also talks about returning to work after exposure to COVID-19. And then finally, this checklist gets into issues such as mental health and well-being. So it's a really useful checklist. If you haven't had a chance to take a look at it, I recommend you do so. And then the second checklist that has been posted on the CDC website is intended for employees. And this particular checklist gets into issues of monitoring for COVID. It talks about symptoms, how to do self-monitoring, what a close contact is. Some of the other issues that are addressed in the checklist for employees includes what social distancing is and what's appropriate, what's not, the purpose of face masks. It gets into cleaning and disinfecting of equipment and tools on the website. And then also, similar to the employer checklist, it discusses mental health issues and gets into issues such as the role of stress, conflict at home, sleep schedules, mindfulness techniques. So lots of really important topics related to mental health, because we recognize how the pandemic can adversely affect mental health of employees. And then there's a whole list of resources at the bottom of the checklist for employees. So that's the two new checklists that are now available on CDC's website. And then I had a few things I wanted to touch on related to the CDC publication, Morbidity Mortality Weekly Report. And so this is a graph from one of the articles that was put out recently. And this article addresses COVID-19 cases in children, adolescents, and young adults. And it indicates that the number of cases really for all of those age groups has increased very significantly, going back to September, October, November, December timeframe. And so these lines represent the various age groups. So the line at the bottom is age 0 to 4. The next line up is ages 5 to 10, followed by 11 to 15. And basically the main point here is that the cases have increased significantly in recent months, and it's increased for all age groups. So it's just important to remember that there's issues related to universal and proper wearing of masks and what's being done in schools with students and teachers and staff members. But really, for many of these young people, it's increased. It's not to the same extent as older Americans, but it has increased for each one of those groups, and it's fairly parallel in terms of the uptick. So just wanted to mention that article that came out recently. I also wanted to point out that there was an article, MMWR article, about how European countries that implemented stricter mitigation policies earlier in the outbreak tend to report fewer COVID-19 deaths. And so this is a graph showing various countries and the deaths that have occurred. So the deaths are on the left-hand side. It's the y-axis. So obviously, the higher up you are, the more fatalities that have occurred. And basically, it's just indicating that if more stringent policies were implemented earlier in the pandemic, it resulted in fewer fatalities. So that's an important aspect of how various countries address the pandemic. And then the last thing I wanted to just touch on briefly, this is another article that was in a CDC publication, and it covers trends in county-level COVID-19 incidents. And what this gets into is the fact that the governor of Kansas issued an executive order requiring mask wear in public spaces. But the way it was put in place, it allowed counties to opt out. And so the interesting thing is that they went back and did a statistical analysis of the counties that followed the mask rule. There were 24 of them, and then 81 counties that didn't follow the masking rule. And there was a significant difference between the two counties. So for basically the counties that did not have a mask mandate, the cases of COVID-19 increased by 100%. The cases that did implement a mask mandate, it decreased. So it just goes to show that community-level mitigation, such as wearing of masks, as well as physical distancing, staying home when you're sick, and practicing good hygiene can be effective. And so that's kind of the update that I wanted to cover. Here's some of the references or links that you may want to check out with more information on COVID-19. And with that, I'll go ahead and turn it back to Jess so she can talk about the ventilation guidance and the survey that was done. Jess?
Thank you, Scott. So just really briefly to go through some of what CPWR has been working on in the area of ventilation. I wanted to share that we've been working very closely with we have ongoing work with them, but two of the recent efforts related to ventilation was administering a short survey and developing ventilation guidelines for construction. We've been having conversations around this and gathering information. And the survey that we did took place the week of December 11th to 18th. We just did it with a convenience sample. It was a brief confidential survey. We got 105 responses. 56% of those were construction safety and health managers or directors. 30% were contractor or employers. 10% were safety and health consultants, and then 3% were project owners. We found that when asked about what guidance they're using for ventilation for COVID-19, almost half of the participants surveyed were currently using OHSA's ventilation guidance. 30% are using CDC NIOSH guidance, and 25% said they're using other guidance from what was listed in the survey, which included OHSA, CDC, ASHRAE, and AIHA. When we asked about what type of work area or structure their projects include, only 25% indicated use of temporary structures to protect workers from the cold, and 56% said that they have projects underway or planned between December and May that would require working in enclosed work areas. So based on that, we asked about strategies that were being employed or planned for, and found that they most often included opening windows or other fresh sources of fresh air, local exhaust ventilation, making sure unit ventilators are clean, and using fans to blow air away from the workers. Less often mentioned was air cleaning technologies such as UVGI, portable room air cleaners, providing maximum ventilation rates before and after shifts, and taking steps to maintain a humidity of 40 to 60% in the work area. Based on those survey results and the other conversations that we've had, we worked closely with the work group again on creating a guidance document. This is a preliminary document. We plan on updating it as information becomes available, and it can be found at the link on the screen. I'm also going to put the direct link to the PDF in the chat right now. And it sort of just provides a quick checklist of tips for improving ventilation at indoor construction sites or enclosed work areas. So I think that covers everything I wanted to share. And let me go ahead and pass it over to Dr. Levin now to get us talking about vaccines. Jeff, you should be getting control of the slides.
Thank you so much, Jess, and I appreciate the invitation from CPWR to provide a bit of an update about COVID-19 vaccination, particularly as it relates to the construction workforce. Today's brief presentation is by no means comprehensive, but I did want to tell you a little bit about what I was going to be covering today, starting with the particular vaccines that are already out there, that is the COVID-19 mRNA vaccine technology, followed by a little bit of a discussion about vaccine safety and development of these vaccines, why it's important, what the benefits of receiving the vaccination are, a few facts about receiving the vaccine itself, perhaps potential common side effects that one might expect, and some tips in terms of how to address those side effects, as well as the all-important continuing public health measures that everyone should participate in, irrespective of their receipt of the vaccine for the foreseeable future, and we'll talk about those later on. I did want to just take a minute to let folks know what we're doing here at the University of Texas Health Science Center in Tyler, Texas, in collaboration with CPWR and NIOSH as it relates to the vaccination process. And then hopefully leave plenty of time for questions, particularly those that have been submitted at the time of registration. So to begin with, what are mRNA vaccines? So I want to emphasize that though these vaccines carry a piece of genetic material, this is different than the genetic material that we normally think about when we think about our genes. This little bit of genetic material teaches our body cells how to make a harmless piece of a protein called the spike protein that is actually found on the surface of this virus, the SARS-CoV-2 virus. Once that instruction is given to our cells, our bodies and our cells actually destroy or eliminate this genetic material fairly quickly. What then happens is that this harmless piece of spike protein gets displayed on these cells, and it causes our body to have an immune response that will then produce antibodies that will protect us should we become infected or exposed to the SARS-CoV-2 virus inside of our bodies. So let me just reemphasize that this does not affect our DNA. It does not affect our chromosomes. It has nothing to do with that whatsoever. The segments of mRNA do not get inside the control center of the cell. They just get into the cell and they start this process. Let me also emphasize that these vaccines don't cause COVID-19. They don't have all the elements like the virus itself in order to cause the disease. So the thought that these vaccines could result in COVID-19 directly really is not the case. Finally, just to say, there's a much discussion out there about how brand new this is. This is new technology. We're very concerned about it. It is important to tell you that although vaccine manufacturing using this methodology is new in terms of approval of these types of vaccines, this science has actually been going on for some time. This technology development has been going on for some time, and we do have a fair amount of experience with it. So this is just a little bit of a graphic that really explains just what I've talked about. You can see the virus. It has these little spike proteins on the outside. What we do is we capture a little piece of this genetic material called mRNA that codes for a part of the spike protein. We wrap it up in a little capsule that's called a lipid coating, and that's what's actually administered into our arm, as you can see here. Once it gets into our cells, not the control center of the cell, but the cell itself, it causes the cell to make little pieces of the spike protein that just then go on the outer surface, and that signal then gets the body to begin making antibodies so that if we encounter the real virus, then we have a supply of antibodies ready to attack that virus and eliminate it from our bodies. So a little bit about safety. Let me just say this is true really of any kind of vaccine or drug or anything like that that is actually released for use in the market, that these have to go through multiple phases of what we call clinical trials, and that has certainly been the case for this vaccine. When that work is done, the FDA can then issue what's called an emergency use authorization if, based upon these clinical trials and all the information and data collected, demonstrate a couple of things. One, that the vaccine is safe, that it hasn't had terrible side effects or terrible outcomes, and that it's effective, that it has a high level of effectiveness so that taken together, the benefits of people receiving the vaccine far outweigh any risk that may be associated with the receipt of the vaccine. Once that happens, there is a committee that gives advice on immunization practices that then reviews the data and makes recommendations about how the vaccine should be released, unfolded, who it should be given to, what age group, what sequence, that sort of thing. That actually happened with the 2 vaccines that are out there right now in use. And in this instance, with those COVID-19 vaccines, they have been held to the same safety standards as all other vaccines that were developed previously for other kinds of illnesses. Now, we don't stop there in terms of safety. It's very important that we continue to monitor things that could happen when people receive the vaccine. And there are a number of ways to actually do that. I've just illustrated a couple of here. One is called the VAER system, the Vaccine Adverse Event Response System, where, if there is an adverse event to a vaccine, then a healthcare professional or other individual could report into this system that that's occurred. And then there's also an app, which when you receive the vaccine, we encourage people to put on their phone so that you can receive daily checks as to whether or not you may have symptoms or other important side effects that we need to know about and we need to compile so we understand what's going on with the safety of the vaccine. So bottom line, the safety of these COVID-19 vaccines has been a top priority start to finish. So why get it? Why is it important to get it? Well, it can help you keep from getting COVID-19, probably one of the most important reasons. It has been shown to have very high, what we call efficacy, meaning it's very effective at doing this. Now, it is not effective at that level with one shot, and I'm going to get to that in just a minute. But when I say here that it's 90+% effective, it's probably for both of these vaccines closer to 95% effective, at least based upon the trials that were done in order to pursue an emergency use authorization. Depending on the vaccine that you get, a second shot of that same vaccine 3 to 4 weeks later after your first shot is needed to get the most protection that can be offered by the administration of that vaccine. So in order to get to that effectiveness level, it is important that people pursue getting both vaccines in a timely manner. I will try to address timely in just a minute. Because I'm sure there are many questions about, well, if the supply is slow, how do we ensure that we do this in a timely way? COVID-19 vaccines that require 2 shots may not protect you until a week or 2 after your second shot, okay? So that's a very important point. So first, rule number 1 is, obviously, when it's available to you, making every effort to ensure that you get both shots. And secondly, don't assume that when that second shot goes in your arm, you're immediately fully protected, right? It takes the body some time to ensure that it can build up that immune response. So it does take a week or 2 to gain that level of protection that we all are very glad is provided by these 2 vaccines. Next, it can help you if you should be exposed and if you get infected with the virus, it has been shown to be able to help you to keep from getting seriously ill with this virus. Okay, so that's a second big advantage to why you would want to receive this vaccine. It is a safer way than natural immunity to help build protection. What do I mean by that? Well, what I mean is that, because you're not really receiving the real virus to generate immune response compared to if you became infected with the real virus, this is a lot safer to have a few minor side effects than to risk getting the real disease that could land you in the hospital or could even cause death, as we have clearly seen. An important tool to help stop the pandemic is probably another one of the greatest benefits. And that really comes with the more people who we can ensure get fully vaccinated, so that as much as 70, 75, or 80% of the population is actually vaccinated with this vaccine. So, in brief, I just want to mention that the vaccine can be administered. These are a few of the questions about specific groups who may or may not be eligible to receive the vaccine, not based upon their work category or their occupation. So these vaccines can be administered to individuals who have medical conditions that we call immunocompromising conditions, or people who may be on treatment that may compromise their immune systems. It is not that being immunocompromised would put you at risk from the vaccine itself, but rather people who do have suppressed immune systems may not respond as effectively to the vaccine, meaning they might not build as robust an antibody response. And so that's really the only concern there. It is not a concern of a direct safety risk from the vaccine itself. The vaccine is contraindicated, meaning it should not be received by a very small subset of individuals. First of all, I will just say at this point in time, it is not available to anyone under the age of 16 for one vaccine, 18 for another, because we don't have adequate clinical trial information at this point to make sure that we can say it is fully safe for those individuals. That information is currently going on. It's being studied so that eventually the vaccines can be made available to younger age groups. In the meantime, the only probably major reason is if someone has a severe or immediate allergic reaction that we call anaphylaxis to the vaccine itself or to a component of the vaccine. Now, I'm not going to spend a lot of time going into detail about that, except to say that a couple of weeks ago, there was a report released in the Morbidity and Mortality Weekly Report from the CDC that actually looked at the fact that for the Moderna vaccine, there had been 4 million doses already given by the time that report was released a couple of weeks ago, and there were only 10 episodes out of those 4 million where there was a case of anaphylaxis. That occurred within the first 15 minutes of receiving the vaccine for 9 out of those 10 individuals. And there were meaning that the reaction could be addressed very quickly, and there was no single very serious ultimate outcome following that as a consequence. So the point is that severe reaction you've been hearing about occurs very infrequently, probably not so much more frequently than other vaccines and medications, although it's not a direct comparison. It is unknown at this time whether or not we can safely say it should be administered to pregnant or lactating individuals, just simply meaning those women who are nursing across the board. But what I will say is that what is being encouraged, because we don't have that full information yet, is that is something to be discussed between an individual and their physician. Now, I will mention the fact that there is a significant risk for pregnant women who get the disease, who are infected with COVID-19, like other groups who may be infected. And it could, being infected, with the virus. Those who do get the virus, that virus actually could also cause what we call preterm birth, meaning a premature birth that could have its own consequences. So again, it's a matter of weighing the risks and the benefits, but that is something really to be discussed with your individual healthcare provider. So bottom line is we don't keep those individuals from getting the vaccine, we would encourage that, but it really should involve a discussion between you and your healthcare provider. We do require or recommend that there be observation of 15 minutes following receipt of the vaccine. I think based upon the information I just reviewed, you can readily understand why. To look for this issue of anaphylaxis. If there is such a history for any kind of medication, that type of severe allergic reaction, we recommend at least a monitoring period of 30 minutes. And finally, at the cost, there's been a lot of discussion about cost. It is not and should not be an obstacle. The federal government is providing the vaccine itself free of charge to people living in the United States. However, it is true that your vaccination provider can bill your insurance company, Medicaid or Medicare, for an administration fee for the vaccine. But the vaccine itself is free to individuals in the U.S. Okay, very quickly to wrap up, common side effects. So it is normal when you receive a vaccine, it is not unusual, I should say, to see your body build protection against the organism for which the vaccine is being given. And that is no different in this case. So it is not unusual for people to develop a little bit of pain or swelling at the injection site. It can become a little bit more moderate or severe, particularly with the second dose. You can see some moderate grade fever, chills, being tired or fatigued, having a little bit of headache. But one of the important things that I'll mention is that most of these symptoms are short-lived. They usually last for a day or two and they disappear. They can be readily addressed by over-the-counter medications like ibuprofen or Tylenol if you have no other reason not to take those kinds of medications. And maybe with some local care with a cool, wet washcloth. Certainly, if the area becomes increasingly red or tender or the symptoms get worse and worse and don't disappear after a few days, you really should consult your healthcare provider. However, again, it is important to get the second shot, even if you have minor side effects from the first, in order to maximize your opportunity to be fully immunized against the virus. So I did emphasize this earlier. I did want to say that even though you may receive the vaccine, these mitigation measures that have been addressed earlier really should continue to be emphasized, regardless of who you are, up to and including those of you who work in the construction trade. So wearing a face covering, washing your hands frequently, maintaining that social distancing that we've all become very accustomed to are things that you should continue to do. I am providing some information resources here that will be available to you, and I also did want to say briefly that here in Tyler we are working closely with NIOSH, with CPWR, because we hope to actually look at a few of these questions and really try to help craft some very informative, useful messages for individuals involved in the construction trades so that they can have a better understanding of the vaccine issue and so that they can have a reliable information source in making decisions about receiving the vaccine. So with that, I again appreciate the opportunity to give you a little bit of an update about vaccines today. Jess, back to you.
Okay, thanks, Dr. Levine. We appreciate that update, and we will now go ahead and get into the Q&A portion of our webinar. And we're fortunate to not only have Dr. Levine from University of Texas, but also Dr. Trout from NIOSH, both extremely knowledgeable in this area. The first question came in through the registration, but I've also noticed that it also came in through the chat, and that has to do with will construction workers, where do they fit in the rollout of the vaccine, or sort of where are they eligible in terms of getting it? So let's start with Dr. Levine, and then if Dr. Trout wants to add anything, handle it that way.
Be happy to, and I really do appreciate Dr. Trout and his guidance in helping respond to many of these questions. They are very important questions, and they can be very confusing. So the answer to this question is, in fact, a bit confusing because there is a related question about whether or not construction workers are considered frontline essential workers. That seems to be something that is on everyone's mind. The reason for the confusion, at least as I see it, is that there are more than one system or way to classify which occupations and types of workers are considered to be essential. We kind of use that word, but we interpret that word differently depending upon the issue we're thinking about or our frame of reference. So, for instance, something called CISA, or the Cybersecurity and Infrastructure Security Agency, includes a broad array of workers and occupations who support construction, maintenance, and rehabilitation of critical infrastructure. So by that definition, we would think, okay, well, many construction workers are included in the definition of essential workers. They also define frontline essential workers as the subset of essential workers likely at highest risk for work-related exposure to SARS-CoV-2 because their work-related duties have to be performed on-site and involve being in close proximity to the public or to their coworkers. Okay, well, that's a long definition. That's a mouthful. But that is how that one organization defines an essential worker. On the other hand, and I'm not going to go through the same level of depth, there is another coding system that we use regularly here in the U.S. called the North American Industrial Classification System, or the NAICS, that also has a series of codes that includes the construction sector. All that being said, the driver for administering the vaccine in a prioritized or phased approach really has been driven by that organization I mentioned to you earlier called ACIP, or the Advisory Committee on Immunization Practices. And what has occurred in recent days is that they have said essential workers in construction fall into phase 1C, but when they were doing that in their documents, in their referencing documents, they gave an example that that refers to or includes housing construction. So I don't think anyone feels or thinks that it's likely that they meant to single out just housing construction, or for that matter, that there won't in due course be some clarification about the fact that most construction workers should likely be considered in the phase 1C group by ACIP CDC. So I think that is in a state of evolution. The bottom line is you can see what has been done in this regard. I think Jess will be posting in the chat box a link that the CDC and ACIP have developed that relates to the definition of essential workers and how that cross-linking has been done to show that many groups of construction workers do fall into this 1C group. Just one quick additional point, and that is that it's important to recognize that local jurisdictions like states and local health departments have primary responsibility for vaccine planning and implementation. So prioritizing at the local level is a little bit variable around the country. And the CDC does have guidance stating that plans don't necessarily have to vaccinate all individuals in one phase before they start vaccinating in the next phase. And what I mean by that, or another way to say that, is you can begin to vaccinate in phase 1C before you've vaccinated every last individual in 1A or 1B. So And the CDC, I think, has made clear that that is an acceptable process. But those determinations really are largely made at the local level based upon a lot of factors at the local level up to and including the actual vaccine supply. So I'm going to stop there. I know that was a really long answer. That's probably one of the most complicated questions I think we'll be addressing today. Dr. Trout, is there something to add to that?
Yeah, thanks, Dr. Levin. I'll just add that was a great, it is confusing, and I'll just say that despite that fact that it is confusing, there's been a tremendous amount of work that's been done by the CDC and the ACIP and other groups, including collaborations with the states, to try to make it as uncomplicated as possible. But it is a huge topic, and I did post a link in the chat box, really exactly what Dr. Levin was talking about, because the CDC does provide guidance that, despite the fact that the state and local jurisdictions really have ultimate control on what happens in their jurisdiction, the CDC does have guidance that says, even though they define these phases, phase 1A, 1B, 1C, it is totally appropriate based on local circumstances to not necessarily wait for one phase to complete before you go to the next. So that's what they refer to as, implementation, across phases. So I put that link if you're able to access that. And that's all I'd like to add. Thank you.
Okay, we'll go to the next question. Again, this came in through the registration. It says, what is your opinion about releasing all the vaccines now available? Are you concerned that there will not be enough for the required second dose? What's the status of other vaccines that were in the pipeline?
The strategy in general has really moved in the direction of ensuring that we get shots in arms. I think people are really beginning to hear that. Obviously, we have to plan appropriately based upon supply so that we can ensure individuals will get their second vaccine in a timely manner. But that being said, the hope is, and certainly the direction that we seem to be moving, is that the supply will catch up with recommended dosing recommendations, particularly for these two-dose vaccines. Regarding the one-dose vaccines, I mean, the word currently is that these other vaccines are continuing to accrue sufficient effectiveness data so that they can pursue the same safety process, go through the same rigorous safety process through the FDA and ACIP that the other vaccines actually did. I do want to just add that people who do get the first dose of one of these two vaccines that are available right now, it is important to try to pursue getting that second dose. Certainly no sooner than in the recommended 3 to 4 week time frame. There is some suggestion that you could stretch that out based upon vaccine availability to about 6 weeks or 42 days and really not change the picture of effectiveness. When you do that, there is no reason to start a two-dose vaccine process over again. So I think the bottom line is that we should not be overly cautious and waste vaccine. We should do everything we can to try to begin to put vaccines in arms with reliance on the fact that the supply chain will continue to increase in the coming days. Dr. Trout, anything to add to that?
Thanks, Dr. Levin. Nothing that I agree 100%. I'm going to add a link for those of you who like to see web pages. There's an awful lot on the web. I'm going to add the link right now that discusses the flexibility that the CDC mentions and what Dr. Levin just mentioned on how the doses may be given in, on what they would say, extraordinary circumstances. When it's required, the doses can be spread out more than what is recommended initially, or even, variations between the types of vaccines. Again, that would be unusual circumstances, but this is all, as Dr. Levin pointed out, to really get as much immunity going as possible. Over.
Okay, thank you very much. I'm going to direct this to Dr. Trout. Again, this is through the registration. It says, initially to Dr. Trout, what are your thoughts on employers making vaccinations mandatory for their employees? How would you approach this? Dr. Trout?
Oh, yeah, sorry. Just adjusting my volume. Yeah, so a couple issues I'll just point out. One is, the first point is that, as we all know, I think these two currently approved vaccines are approved under what the FDA calls their emergency use authorization. They are safe. This is a standard FDA practice, as Dr. Levin mentioned. However, it would be unusual in terms of past practice to have a vaccine program or a vaccine being made mandatory for a vaccine approved under an emergency use authorization. So that's one thing. The second thing is there are several laws and both federal and even state that need to be considered when an employer would want to consider making a vaccine mandatory. So we are not really able to get into those legal issues. And if that comes up in your workplace or for your workers, I recommend getting attorneys or your legal counsel involved. But currently on the, and I'll post, in a second, I'll post a link to the EEOC, Equal Employment website that discusses this issue. But currently on that website, the general recommendation is that probably at this point, workplaces should consider making the vaccine available, but on a voluntary basis. And I'll turn that over to Dr. Levin. Anything to add or clarify what I said?
No, I think that's perfect. I don't really have anything to add. Like so many of these things, it is a complicated issue, but it's not unique, certainly, to the SARS-CoV-2 vaccine, because I think the same is true of many other kinds of vaccines that are used in the work setting that are available out there. So I did post one piece of information in the chat box. I'll go ahead and copy the other that I think you're actually referring to, which is an update from the EEOC for anyone who might wish to access that.
Okay, thank you very much. The next question, again from registration, is where do construction workers that are routinely working in high-risk environments, such as like renovation of hospitals or nursing homes, where do they fit into the eligibility for the vaccine and the prioritization? Let me direct that to Dr. Trout first.
Yeah, that's a great question. And again, there is probably no one answer for the whole country. As we mentioned earlier, the ultimate rollout of these vaccines is by state and local jurisdiction. That's the way the system operates. However, certainly, I think it's very reasonable that construction workers or folks in the construction trades working in a healthcare institution could easily be categorized in the same as other workers in that healthcare institution. In other words, be considered, equivalent to the healthcare worker for purposes of vaccination. And in fact, we know that we have anecdotes, or we've heard stories that has happened in some parts of the country. But I can't say that is any type of, certainly not any type of enforceable rule or standard, but it certainly would be reasonable for that to happen.
Okay, thank you. I'm going to try to pick up the pace a little bit because we're running short on time, but there was a question about record keeping, and it says regarding not only the vaccination, but also individuals that have acquired natural immunity is a monumental task in terms of keeping track of that. Do you have any recommendations for all aspects of vaccinations when it comes to data management of immunity? Let me direct that towards Dr. Levin.
So, brief, the second piece, you're right, that tracking individuals who've developed natural immunity, meaning that they've had a test to show that at one point that they either are infected and recovered or they have developed antibodies, is a sort of completely separate record-keeping system through different public health agencies, and don't want to spend a lot of time talking about that. What I will say regarding the vaccine itself is that recipients of the vaccine receive and should maintain a vaccination record card, and including both their first and second dose for these two vaccines. I would certainly urge people to maintain that. Most different states have different systems for keeping record on who's gotten the vaccine. For instance, here in Texas, we use something called MTRAC, where all of that data are fed up to the state level, the state public health agency, to record who or who has not received the vaccine. So the answer of the question is absolutely correct. Very complicated process, but what I would say is be sure you use the safety response systems, and be sure to keep your card. Two very important pieces of things that you should keep around.
Thank you. Another question. For employers that are mandating the COVID vaccination, would they have any sort of legal liability if there were complications from getting the vaccine? Dr. Trout.
Well, that really is a legal question, and I don't think I'm qualified to answer that. I'm not aware of workplaces mandating the vaccine, but ultimately that is something for the attorneys to work on.
Okay, and then another question is, how should employers handle employees that refuse to return to work because their coworkers have not been vaccinated? Dr. Levin.
So, I think an employer wants to and is expected to provide a safe work environment, and that means safe if from hazards in the workplace, whatever source they may actually come from. Honestly, before a vaccine became available, that was accomplished by, wear a mask and wash your hands and do all of those sorts of things. The vaccine is just one added piece. Now, there were several questions about requiring people to get vaccines and so forth. I think the main thing right now is to really rely on encouraging our coworkers to get the vaccine if they are eligible when it becomes available to them, because what they're doing essentially is not just protecting themselves, but they are protecting their coworkers, and they are ensuring that the employer is fulfilling their responsibility of providing a safe and healthy workplace.
Thank you very much. Another question has to do with Are there any proven practices for increasing worker trust, acceptance, and buy-in on getting vaccinated? Dr. Trout, any thoughts on that?
Yeah, and this really gets to just echo what Dr. Levin just said. It's about education, communication, encouragement, and really I think if not already posted, there is a great website that we can point you to that's essentially called the Essential Workers Vaccine webpage that has that information on the page, but also things you can download, posters, all kinds of communication material to really get the message out, encourage communication and education about this whole issue. And that's really, I think, the way to go.
Okay, thank you. And then after a person's been vaccinated, should they continue to wear a mask and practice social distancing? Dr. Levin.
Sure, absolutely yes.
Okay, very good. Thank you for that. And another question was, they said, I'm worried about rushing to give more people one dose as a crowd pleaser if they really need a second dose for real protection. What's going on with the two-dose situation for the vaccine?
I think I alluded to this, earlier. Obviously, obviously, what we're trying to do is, as the supply of vaccine improves, try to phase in different groups to receive the vaccine. And as I mentioned earlier, the goal right now is shots in arms, in anticipating that the supply will continue to improve so that second doses will be available over the course of time to other individuals. If I could just add, I did see a quick question in the chat box because I think it's a corollary to this. The question was, which is the better vaccine, the Moderna or the Pfizer vaccine? My answer to that question is the better vaccine is the one that gets in your arm. So whatever is available to you of those two, for all intents and purposes, there is no one that is better per se than the other. If it doesn't get into your arm, it doesn't do you any good.
Okay, thank you very much for that. And then there's a question about OHSA and potential for an emergency temporary standard. The question is, could a vaccination be required in a potential ETS that OHSA would put out? Dr. Trout?
That I'm sure is a very active topic of discussion. Again, by precedent or what we know from history is that we know that OHSA can make a I'm not saying just in general, OHSA can make a standard that includes vaccination being offered. For example, we know with the case with hepatitis B virus. However, it's yet to be seen for COVID, and so I think we'll find out in the coming time. I think I'm speaking for OHSA, but I know they're thinking hard about this issue right now.
Okay, thank you very much. We're at 3 o'clock at this point. I'm just going to take a quick look here at the chat to see if there's other. There was a question about how long the vaccination, how long you have immunity after getting the vaccination. Any thoughts on that as we get ready to sort of wrap things up?
There have been projections, some limited studies to date, in smaller groups. Initially, some thought that up to 3 months to 90 days, some now looking at 8 months or longer in terms of protection. So I think the real answer to that is it is an evolving situation. If we use our prior experience, in general, I think we can feel fairly comfortable about the lasting of this immunity, for the near term or a season. Beyond that, there's really just not enough evidence to say for certain.
Okay, very good. I think with that, we're past 3 o'clock. I'd like to go ahead and wrap things up. I want to thank Dr. Levin, Dr. Trout for their expertise and time preparing for this webinar. I want to thank CPWR and Jessica Bunting for hosting, and also for all the participants that called in and asked questions on the chat. I hope this was beneficial, and we'll be planning another webinar soon. So stay tuned, and looking forward to talking to you again soon. Take care, everybody.